Hello and welcome to Workers Comp Unwrapped, the podcast that simplifies workers' compensation for physicians. So, let's get started. A patient falls from a 3-story scaffold, suffering an undeniable catastrophic spinal fracture. You would think the billing for a completely obvious severe workplace injury like that would be, an absolute guarantee. But statistically, it is the exact opposite. Today, we are looking at why the most obvious catastrophic injuries are actually the most likely to have their claims delayed, denied, or just drastically underpaid. Welcome to Workers Comp Unwrapped, Season 4. I'm your host, Anik, and I'm joined today by our industry expert, Angela.
We have a very specific mission for this deep dive into the source material. We're unpacking the high-stakes, heavily scrutinized world of billing for catastrophic workers' compensation claims.
It is so great to be here, and when you look at the sources regarding these catastrophic files, specifically things like traumatic brain injuries, spinal trauma, severe burns, a clear baseline insight just emerges immediately.
Right, it's not just a standard process.
Exactly. These cases, they demand an entirely different operational approach than your standard run-of-the-mill injury claims. I mean, we are dealing with incredibly long recovery periods here. Multiple highly specialized providers too, right?
Oh, yeah. Multiple providers and treatment timelines that can stretch for years, honestly, which, inherently triggers heavy payer scrutiny.
The stakes are just astronomical, which means the margin for error is essentially zero for you guys listening. We need to start by breaking down exactly why a practice can't just, use their standard billing workflow for these massive files. Like, what is the fundamental difference in the mechanics of a catastrophic claim that necessitates this complete mindset shift?
Well, the fundamental difference is really the sprawling, layered nature of the severity itself. In a standard claim, the treatment pathway is usually linear.
Step A to step B to step C.
Exactly. But with catastrophic injuries, the medical response happens concurrently across multiple facilities and entirely different specialties.
So everything is happening at once.
Right. You are coordinating initial acute surgeries and then stepping down into complex rehabilitation, initiating long-term pain management, and integrating highly specialized outpatient care. The patient's entire physiological baseline has been altered.
Wow, so it's massive.
It is. If the billing department tries to process that sprawling network of care using the same linear transactional workflow they use for, like, a simple sprained ankle, the system immediately breaks down.
It is kind of like the difference between writing a short story and building this complex, epic narrative.
Yeah.
A standard claim is brief, right? It has a straightforward beginning, middle, and end.
Right.
But a catastrophic claim is a massive timeline with dozens of different characters. You've got the trauma surgeons, the physical therapists, the neuropsychologists, all of them adding their own chapters to the file at different times.
That's a great way to put it.
There are exponentially more touch points, which means there are exponentially more chances for the narrative to just contradict itself.
And the entities reading that narrative, the payers, they are highly incentivized to find those exact contradictions. Because the financial exposure on these catastrophic claims is so exceptionally high, payers do not just passively review these files.
They're digging in.
Oh, absolutely. They run them through sophisticated scrutiny. They're often utilizing these automated algorithms that are literally designed to flag any slight code mismatch, chronological error, or overlapping treatment.
So they are actively hunting for plot holes.
Yes, perfectly said.
If the documentation from the physical therapist doesn't perfectly align with the surgical discharge summary, that isn't just a minor administrative error, is it?
Not at all. It gives the payer immediate, justifiable room to push back, freeze the payment entirely, or just deny the subsequent care completely.
Man, that is intense.
It is. The documentation must meticulously reflect the specific evolving nature of the injury. And we see this breakdown most clearly when we examine the big 3 catastrophic injuries highlighted in the sources.
Yeah, let's get into those, because the billing friction for each of these injury types is incredibly unique. Let's start with traumatic brain injuries, or TBIs.
Right, TBIs.
The sources single these out as notoriously difficult to capture accurately in a billing cycle. Now, we all know the cognitive and emotional deficits of a TBI are severe, but why does that specifically create a nightmare for the billing department?
Well, it's mainly because the timeline of a TBI is rarely linear, And the symptoms are largely invisible to standard imaging after that initial trauma has passed.
Because you can't just take an X-ray of a memory problem.
Exactly. The physical contusion might heal up fine, but the ongoing functional deficits like severe memory issues, the inability to focus, erratic emotional changes, massive disruptions to the sleep cycle, those evolve unpredictably over time.
So you're dealing with a moving target.
Yes. You are trying to bill for ongoing high-level care for symptoms that fluctuate day by day.
Let me push back on this a little bit, just based on what you actually see clinics experience. A facility might say, look, we have the initial emergency room records and the MRI proving the massive trauma of the TBI. The injury is firmly established. It feels like payers constantly use any slight sign of patient improvement during a follow-up visit as a weapon to abruptly cut off necessary maintenance care.
Oh, they absolutely do. And the worst part is they use the clinic's own documentation to do it.
Wow.
The reality of payer behavior is that confusion or any kind of contradiction immediately leads to delays. I mean, imagine a scenario where the patient sees a neurologist on a Tuesday. The neurologist notes, patient is resting comfortably, headaches are subsiding, showing signs of improvement.
Okay, sounds like good news.
Right. But then 2 days later, that same patient sees an occupational therapist, and the therapist documents patient is completely unable to concentrate on basic tasks and cannot function.
And to the payer's automated review system, that is a glaring discrepancy.
Yep. The neurologist's note is used to justify denying the occupational therapist's continued treatment.
So without a clearly documented clinical explanation connecting those two realities, like explaining that physical rest does not equate to cognitive endurance, the claim is just immediately flagged.
Exactly. The clinic must continuously prove the ongoing medical necessity of every single visit. They cannot just coast on the severity of the initial injury.
That perfectly illustrates why relying on the initial trauma is such a trap. Every single update has to justify the next step in the clinical pathway. That logical progression is crucial for TBIs. But how does the billing landscape shift when we look at the second of the big three? Spinal trauma.
Well, with spinal trauma, the sheer volume of specialized care is the primary friction point. You are navigating emergency care, advanced diagnostic imaging, highly complex surgical interventions, and then you're moving into intensive inpatient rehab.
And outpatient physical therapy.
Yeah, outpatient PT, ongoing specialized pain treatment, and often permanent home modifications or, durable medical equipment.
That is a staggering amount of concurrent coding. If a clinic is submitting bills for surgical follow-ups, physical therapy, and durable medical equipment all in the exact same month, how do you prevent the payer from viewing it as duplicative or excessive care?
By ensuring the billing reflects absolutely flawless chronological logic, it is all about strict sequencing. The documentation must explicitly establish causality at every single step.
What do you mean by causality?
You have to document exactly what happened first, clearly explain the physiological reason a subsequent service was required, and show how that specific service logically followed the original spinal trauma.
Okay, so it has to follow a chain of events.
Yes. For example, if the billing for a custom wheelchair is submitted before the surgical notes formally establishing the permanent lack of mobility are processed, the payer system just kicks the equipment bill out completely.
Sequence is everything.
Yeah.
The billing codes have to tell the exact same chronological story as the clinical notes, literally down to the day. That makes sense for spinal cases, where the treatments happen somewhat sequentially. But what happens when the treatments are intensely concurrent? That brings us to the third major category: severe burns. The sheer length of the timeline has to be the biggest vulnerability here, doesn't it?
The timeline is massive, yes, but the concurrent nature of the care is what truly breaks down the billing process. Burn care spans multiple clinical settings over incredibly long periods of time.
Right, because it's not just the burn itself.
Right. A single patient is often navigating intense initial wound care, multiple stage skin grafting treatments, rigorous infection control protocols, and vital psychological support services to help them cope with the trauma, and it's all happening at the exact same time.
And because that is happening across so many different specialists, often using entirely different electronic health record systems, I imagine the external documentation turns into a chaotic mess very quickly.
Oh, it becomes a complete labyrinth. And a messy record directly jeopardizes your revenue. When you have concurrent treatments, you have concurrent billing submissions.
Makes sense.
So if the wound care nurse's notes on tissue viability do not perfectly align with the infection control specialist's timeline regarding localized sepsis, the payer halts the entire process.
Wait, really?
Oh, yeah. They will not pay for the skin graft if the infection control note suggests the site wasn't optimally prepped, even if the surgeon already performed the procedure.
That's brutal. So the lack of synchronization between two completely different specialists results in the facility not getting paid for a massively expensive surgery.
That's exactly what happens.
We have established just how messy these specific injuries get. So let's look at the operational danger zones. Let's explore the most common traps medical offices fall into when they're managing these heavy files. According to the sources, what is the single biggest administrative mistake providers make?
The biggest vulnerability is falling into what the industry calls the assumption trap.
The assumption trap.
Yes. Providers falsely believe that the sheer catastrophic severity of the injury will simply speak for itself. Because an injury is visually undeniable and medically devastating, clinicians and billers just assume the payer will automatically understand the implicit medical necessity of a specific treatment.
That is an incredibly dangerous mindset. It goes back to a courtroom analogy. Imagine a highly publicized, undeniable crime. The entire town saw it happen. The prosecutor cannot just walk into the courtroom, point at the defendant and say, "Come on, Your Honor, look at the evidence, it's obvious."
Right, they'd get laughed out of court.
The judge would throw the case out immediately. You still have to meticulously present the evidence. You still have to systematically prove the timeline, the motive, and the opportunity. The dates, the specific diagnoses, and the treatment paths still have to align perfectly for the jury, no matter how obvious the injury seems to the doctor.
I love that analogy. You cannot skip the burden of proof just because the injury is severe. And falling into that assumption trap accelerates a phenomenon known as case drift.
Case drift.
Yeah. Because the treatment timelines for these catastrophic claims are so incredibly long, the personnel involved inevitably change. You get rotating specialists, new nursing staff, different billing clerks.
Right, people move on, they take vacations, they quit.
Exactly. Over months and years, the clinical notes start to vary in their level of detail. The narrative starts to drift away from its original clarity, and all internal consistency is totally lost.
Case drift. That really is the silent killer of these claims. When that drift actually happens on paper, what are the specific documentation flaws that the payers are immediately catching?
The sources highlight 3 very specific documentation flaws caused by case drift. The first is incomplete detail, specifically describing the what without establishing the why.
What do you mean by that?
Well, a provider will meticulously document that they performed a complex debridement, but they completely fail to explain the updated physiological metrics that made it medically necessary to do it again at that specific stage of recovery.
Right, the payer knows you did the procedure. The code tells them that. But if the narrative doesn't explain why it was necessary today as opposed to last week, the algorithm flags it as excessive.
Exactly. The second major flaw is poor continuity between visits. This happens when the notes from month 6 do not logically follow the documented outcomes from month 5.
It just looks disjointed.
It reads as though the clinician is treating 2 completely different patients. And this is usually because a new provider simply copied and pasted an old note without updating the current functional baseline.
Oh, copy-paste errors. Those are deadly.
So deadly. And the third flaw, which triggers instant denials, is a direct mismatch between the medical clinical note and the actual billing codes submitted.
Okay, so if the CPT code submitted to the payer indicates a highly complex, multi-layered tissue repair, but the doctor's narrative merely describes a standard dressing change.
That is an automatic red flag.
Wow, it looks like upcoding, even if the complex repair actually happened but just wasn't typed out properly.
Exactly right.
So let's shift our focus from identifying these massive structural problems to actively defending against them. Because if you're listening to this, you need practical, actionable strategies to protect your practice's revenue. If a clinic takes on a catastrophic case, what must the operational workflow look like from day one?
It requires a rigorous, uncompromising day 1 checklist. First, you need completely accurate, comprehensive intake information regarding the mechanism of injury.
Got it.
Second, the clinic must aggressively hunt down and gather all supporting external medical records from previous facilities immediately. Do not wait until the payer requests them 6 months down the line.
Proactive, not reactive.
Always. And third, implement a strict internal audit process to ensure every single stage of treatment is clearly documented and cross-referenced before the patient even leaves the building.
But implementing that level of precision requires a massive cultural shift within the office. I mean, we all know medical practices operate in heavily guarded silos. You have the front desk handling intake, the clinical team charting in the back, and the billing department isolated in a completely different wing, sometimes entirely off-site.
And those internal silos are absolutely deadly for catastrophic claims. You have to break those walls down.
How do you even start doing that?
Well, the front desk capturing the authorization, the clinicians detailing the care, and the coders submitting the bill cannot work in isolation anymore. They must share a unified, heavily communicative understanding of the entire case history.
So they have to be talking to each other constantly.
Exactly. If the clinician checks a generic box in the EHR and the coder just blindly translates that into a claim without reading the surrounding context, the claim is dead on arrival.
I can see a massive operational tension here, though, like the tension between speed and accuracy. If a provider has just delivered $50,000 worth of complex surgical and rehabilitative care, the financial pressure to rush that massive bill out the door to get cash flowing must be overwhelming.
The pressure is immense. But rushing a complicated, high-value case out the door without a comprehensive internal review creates devastating downstream problems.
It backfires.
Completely. If you send a sloppy, unaligned bill just to get it out the door, it gets denied. And then that $50,000 sits locked in the appeals process for 18 months.
Ouch.
Providers absolutely must flag these catastrophic cases the exact moment they enter the system. You have to assign a specific, highly trained individual whose sole responsibility is to watch that specific file across all departments. They have to ensure the clinical and financial narrative remains absolutely bulletproof.
So you have to slow down the initial submission to actually speed up the final payment. Taking an extra 3 days to align the narrative saves you a year of fighting in appeals.
Exactly. It's an investment of time up front.
Now, let's address the reality of what happens after that perfectly aligned bill is submitted. Because even if a clinic executes everything flawlessly internally, the battle continues once the file actually lands on the payer's desk. How should providers anticipate and handle the inevitable payer resistance?
You have to accept that resistance is a fundamental part of the system. Due to the massive financial exposure these catastrophic claims represent, payers are essentially mandated to look for any structural weakness in your file to justify delaying or reducing that payment.
It's just baked into the model.
It is their operational model. Your job is to monitor their behavior just as closely as they monitor your codes.
What specific payer behaviors or tactics should a practice be watching for?
You are looking for systemic patterns. Never treat a denial, a request for more information, or a sudden reduction in payment as a one-off, isolated administrative error.
Because it probably isn't.
Exactly. If a pattern emerges, for example, if they consistently deny a specific type of occupational therapy modifier on your spinal trauma claims, or repeatedly claim they didn't receive the surgical notes for burn patients, your practice can respond strategically.
So what's the move there?
You do not just complain to a call center representative. You counter their specific algorithm with a perfectly organized, indisputable clinical record that directly neutralizes their pattern of denial.
You are essentially building an airtight legal defense for every single code before they even have a chance to question it. That is brilliant. We have covered an incredible amount of technical ground today, from the epic saga of concurrent documentation to dismantling internal office silos and outsmarting payer algorithms. Before we close out this deep dive, what is the core overarching thesis from these sources that you want the listener to walk away with?
If you take nothing else away from this discussion, remember this core principle. The injury itself may be catastrophic, but your billing process absolutely cannot be chaotic.
That's a great line.
Thank you. Serious, high-stakes medical cases require intense internal discipline, crystal clear chronological records, and incredibly careful, persistent follow-through across every single department.
The injury may be catastrophic, but the billing process cannot be chaotic. That perfectly distills the mechanism of survival in this space.
Thank you so much for bringing this level of industry insight to the table and helping us map out these incredibly complex operational hazards.
It was my absolute pleasure. Thanks for having me. And to you listening, thank you for joining us on this deep dive into the high-stakes world of catastrophic workers' comp billing. But before you step back into your clinic or your office, I want to leave you with a final proactive thought to examine your own operations. Take a hard look at your internal workflow tomorrow morning. If you were to pull a sprawling, complex file for a catastrophic claim right now, who is the actual storyteller in your building? Who is the one specific person ensuring that the clinician's notes, the front desk's authorizations, and the billing department's codes are all speaking the exact same chronological language? Because if you cannot instantly name that person, your practice might already be suffering from case drift without you even realizing it. Keep your narratives tight, and we'll see you on the next deep dive. Thanks for listening to Workers Comp Unwrapped. If you found value in today's episode, subscribe and share with fellow doctors. Stay informed and keep making a difference in your patient's care.